maternal mental health. As with our previous webinars, one of the presentations focuses on the subject from the standpoint of the mother, while another presentation focuses on the implications for the infant. The third presentation highlights the patient experience and community strategies and programmatic supports. I invite you to put your questions in the Q&A, as our presenters will be available to answer your questions at the conclusion of the presentation. A link to a survey will also be in the chat and mailed to you after the symposium if you want to claim CME and CEU credits. For the sake of brevity, I seldom read the educational credentials of our presenters, but how can I not mention that our first presenter, Dr. Emily Dossett, earned a Bachelor of Arts degree from Stanford University, a Master of Theological Studies from the Harvard Divinity School, and a Doctor of Medicine degree from the David Geffen School of Medicine. She is a reproductive psychiatrist and the first director of Women's Health and Reproductive Psychiatry for the LA County Department of Mental Health. She is the founder and director of a novel services approach that integrates obstetrics, psychiatry, and pediatrics into a collaborative care model across the perinatal spectrum. She is an adjunct associate clinical professor in the departments of obstetrics and gynecology and the Department of Psychiatry and Behavioral Science at the Keck School of Medicine, and has received numerous teaching awards. She has authored many peer-reviewed journals and editorials and has presented at numerous conferences, symposia, collaboratives, grand rounds, and task force. It is clear from her CV and bibliography that it is quite a coup for us to have her present at our symposium today. Her presentation is entitled Maternal Mental Health, an Overview for the AIM Initiative. If we wanted to compose a bio of the speaker we needed for this symposium, it would closely parallel the career of Dr. Denise Shervington. She has authored several peer-reviewed papers addressing health disparities, the social determinants of health, and resilience in underserved communities. Her recent publication is Healing is the Revolution, a guide to healing from historical, intergenerational, interpersonal, and community trauma. She is the chair of psychiatry, professor and assistant dean of education at the Charles Drew University of Medicine and Science, and president of the Institute of Women and Ethnic Studies, which is committed to improve physical, mental, and spiritual health by addressing health disparities and inequities. She is an expert in childhood trauma and adverse childhood experiences, having testified before the U.S. House of Representatives and serving as co-chair of the New Orleans Youth Planning Board Task Force on Childhood Trauma. She will speak about the role of the pediatrician in promoting maternal mental health. Ms. Winona Valentine stands out as a 24-year health equity social entrepreneur, founder, and executive director of iDream for Racial Health Equity, a project of community partners. A celebrated coach, collaborator, and speaker, she is a cultural humility practitioner in healthcare by reframing the narrative from death and dying to healing and hope for Black birthing families. She earned an MBA emphasis in business and professional leadership from Azusa Pacific University, a BA with double majors in Black Studies and Economics from UC Santa Barbara, and a certificate in Early Child Development Administration from Pasadena City College. Her topic today, a community perspective, lessons learned through 2 pandemics. And now to share a little bit about our co-sponsor and co-host, AIM, Ms. Brandy Sims.
Thank you, Dr. Swilly. Good afternoon, everyone, and thank you to the Association of Black Women Physicians, the March of Dimes, and PACLAC for being partners of AIM in this provider training series. For those of you that have joined us in previous sessions, you know that we always start with a brief introduction to the issue of Black infant and maternal mortality here in LA County and the AIM initiative. And I encourage you to visit our website at blackinfantsandfamilies.org to learn more about us after this training. So here in Los Angeles, Black babies are 2 to 3 times more likely to die before their first birthday than babies of other races, primarily from complications associated with preterm birth. Black mothers not only have to deal with the personal trauma of infant death, but they're at greater risk themselves, dying 4 to 5 times the rate of mothers of other races, primarily from preeclampsia and eclampsia, which are complications related to hypertension. Previous efforts to explain and address these rates were focused on the behaviors and characteristics of the mother, such as whether she accessed prenatal care, ate her vegetables, and had financial resources. But research shows that these are not protective factors for Black women. For example, Black women who do not smoke have worse outcomes than white women who do, and Black women with graduate degrees have worse outcomes than white women who haven't graduated from high school. Research shows that the root cause of these disparities is racism. The chronic toxic stress of living in a racist society has a weathering impact on the body that results in poor birth outcomes. This slide shows the physiological impact of chronic toxic stress. So typically, if you're in a stressful situation, such as being chased by a dog, you have an initial cortisol release, and then the situation ends and the hormone release shuts off. But if you're a Black person living in a racist society, having to deal with microaggressions at work or at school, state-sanctioned police brutality, protecting your children from the school to prison pipeline, remnants from redlining that impact your economic potential, people insisting that racism does not exist, and other issues on a day-to-day basis, there is no stress hormone shutoff. This results in negative impacts on the body, and this slide does not address the very real impacts on mental health as well. All of this leads to poor health outcomes, including poor birth outcomes, such as hypertension, preterm birth, and infant and maternal death, and longer-term issues, such as disparities in child development and kindergarten readiness. The COVID-19 context makes today's topic of mental health essential in improving birth outcomes and general health for mothers and babies. Then, when interacting with health systems, Black women often encounter implicit and explicit bias. The anecdotes on this page are from the Listening to Mothers survey, where Black women reported negative experiences with providers. These interactions with the health system can have life-threatening impacts, which is why an anti-racist and trauma-informed approach is necessary when trying to improve birth outcomes. So we cannot overemphasize the importance of the leadership of the Department of Public Health through Dr. Ferreira in initiating the AIM effort and calling out racism as a root cause that needed to be addressed when thinking through solutions. This created space for us and others in this effort to approach this work from an anti-racism and social determinants of health lens. And we've seen the ripple effects nationwide. So for example, since then, counties in Wisconsin and Pennsylvania and other areas have declared racism to be a public health crisis. And recently, the Racism in Public Health Act of 2020 was introduced at the federal level. The Los Angeles County African American Infant and Maternal Mortality Initiative was launched in 2018 with the goal of reducing disparities in Black infant and maternal mortality by 30% in 5 years. In addition to the Department of Public Health and First 5LA, our effort also includes other county agencies such as the Department of Health Services, the Department of Mental Health, health plans, hospitals, universities, and philanthropy. And most importantly, it includes the community itself, families that have experienced infant or maternal mortality, and the Black-led community-based organizations that have been on the front lines of this work long before it was given the attention it deserved from the media, local government, and philanthropy. We've been deliberate about elevating their voices in alignment with the slogan, "Nothing about us without us," and research on public-private community partnerships that supports improvements in effectiveness and sustainability of efforts that are informed by the communities they impact. AIM is not a program or a project, it is a movement. The goal here is to create community infrastructure that supports ongoing community-driven policy and systems change to address birth disparities, while correcting for a history of damaging institutional practices and establishing a sense of self-efficacy within the village of support for Black moms and babies. By self-efficacy, we mean that all of us are empowered to engage in this effort and make a difference in birth disparities. We make up the village and have a responsibility to act within our sphere of influence, whether that's calling a pregnant mom to make sure she's okay, or taking the essential step to disaggregate your hospital data by race. and act upon what you find. Supported by public and private funding, we've been partnering on the design, optimization, and expansion of prevention interventions that can disrupt the pipeline from social stress to physiological stress, such as preconception and group prenatal care, doula care, fatherhood engagement, home visitation, and others, as well as clinical interventions through our partnerships with the March of Dimes and hospital quality improvement effort Cherish Futures for Black Moms and Babies. We are also leading a public awareness campaign. We've established a countywide steering committee and community action teams, launched a pooled fund to support the development of community interventions, created partnerships with insurance providers, and supported policy efforts such as SB 464 and AB 2258. And our healthcare providers are such an important part of the village of this village of care and support. And so we thank you for being here with us today. And again, to learn more about the AIM initiative and ways to join our effort, you can find us at blackinfantsandfamilies.org. And with this grounding, we'll now begin our training on maternal mental health. And we'll be hearing first from Dr. Emily Dossett.
Good afternoon, everyone. Can you see and hear? Okay, I know everyone's muted, but Brandy, is it all good?
Yes, so we can hear you, Dr. Dossett, and we can see, yes.
Okay, perfect. So I'm gonna share the screen here and open up my presentation. And while I'm doing that and kind of going over the objectives of what I'd like to cover, what I would really love is to know who the audience is. It always helps me to know kind of where you're coming from, what brought you to this presentation, what role you play, whether it's as a healthcare provider, a doula, a mother, a grandmother, a community member. So if you don't mind in the chat, feel free to put your name if you would like. You don't even have to put your name if you don't want to, for whatever reason, but just type kind of briefly what role it is in your life that brought you to this symposium today. And I'm going to share my screen while we're doing that. Okay. And where is my chat? Here we go. Okay, so I see, okay, project coordinators with Gabby. I know Gabby. Hi. Psychiatrist, wonderful. Stephanie Teleki, hello. Neonatologist. Oh, Dr. Carlisle, thank you for sharing that. Recently trained postpartum doula, fantastic. Community collaborator, postpartum RN, interested in maternal mental health, OBGYN, educator, research coordinator. Hi, Dr. Muttersbach. Dr. Muttersbach gave me my job at USC, so thank you, Dr. Muttersbach. Pediatrician, fantastic, fantastic, more pediatricians. Currently 35 weeks pregnant, Nikki, hats off to you. This is really great. I've heard of Mighty Little Giants. Jessica, thank you for being here. Social worker. Okay, this is really great. I am so honored to be here. So many of you are coming from the healthcare community. So I am going to actually focus a little bit more on the kind of healthcare side of things. This presentation is longer than I can give. It's 45 slides. I know my limits. I never get through a presentation in time, but you will have copies of all the slides. So what I think I'm going to go over is, in the beginning, what maternal mental health is when we talk about it, kind of from the diagnostic perspective, but then also about medications at the end, not because I'm pushing medications or because I want anyone to go out there and, feel like this is a complete, CME course or anything like that, but it's such a misunderstood area of maternal mental health. And it's one that for some women, about 20% of women who do have maternal mental health issues can actually be really vital. So, and it's often what people haven't heard before. So those are the two pieces that I'll focus on. 1 second. Okay. So the objectives overall is to really show some of these different presentations of maternal mental health challenges, to talk how to engage birthing people in maternal mental health care, to understand common screening tools for perinatal depression and anxiety, and then talk about the framework for med management. And please feel free to put questions in the Q&A. I'll probably do those at the end in the time that's set aside for that, so I can get through as many slides as possible. So I want to say a word about language. One thing that's becoming increasingly clear is that you don't actually have to be a woman to birth a child, in the sense that you don't have to identify as a woman to birth a child. You basically need XX chromosomes and the sex organs to make it happen, but there are trans men, there are folks who are gender non-binary, there are other groups such as Two-Spirit who don't identify necessarily as a woman, but who absolutely can give birth. And so that's where we tend to use now the phrase more and more birthing people, or people who are able to give birth. However, we do also use the word woman very frequently as shorthand, and the majority of people who give birth are women. So just wanted to put out there to let you know kind of where we're coming from that lens of inclusivity. Maternal mental health in LA County, you saw some of the statistics that Brandy put up a moment ago about the disparities in infant mortality and maternal mortality. These figures are striking as well. They're also from the LA County Mother and Baby Survey, or LAM survey, and they basically are just questions that were asked of patients in pregnancy and in the postpartum. Very simple, not a screening tool, not a full diagnosis, but they do give you an idea of how many women endorsed some kind of depressed mood in pregnancy and some kind of depressed mood in the postpartum. And if you look across the chart, you will see that women who identified as Black by far had the highest rates. And the way that I really see this is overlapping with the disparities that the AIM initiative is focused on is, again, this idea of stress. So Brandy talked about toxic stress and the impacts that it has on health. Toxic stress also has effects on mental health. The constant barrage of racism in small ways, large ways, cultural ways takes a toll on mental health. And that in and itself, when a woman starts to actually experience mental health symptoms like depression, like insomnia, like panic attacks, whatever it might be, that in and itself is stressful. And it doesn't matter what her diagnosis is. It doesn't even really matter how severe it is. When someone is suffering from any kind of mental illness or set of mental illness symptoms, the experience of it is incredibly stressful. So mental illness itself, in a word, can be both the result of this toxic stress, and it also, once it's being experienced, can make that ongoing sense of stress even worse. So I would say that's really the crux of how toxic stress and maternal mental health intersect. What I'm going to be talking about is mostly kind of from the physician's point of view, how we think about it, diagnose it, treat it, et cetera. But a lot of the stress that women undergo that leads to poor mental health outcomes doesn't really fall in a neatly diagnostic category. It's living day to day with the stress of being a person of color in our society. So what's normal and what's not normal in maternal mental health? I want to say, first of all, what is considered fairly normal, okay? And those of you who have been around, anyone who's ever had a baby are probably familiar with this term, the baby blues, right? The baby blues is not a diagnosis, it's not pathological, it seems to be a normal experience of having a baby, and about 80% of women at least are affected. It really feels like a lot of mood lability. So by that, mood swings, being very tearful, feeling very easily overwhelmed. I remember after my first son was born, he's 14 now, but I remember going and standing in the shower and thinking, what have I done? And crying and thinking I have 18 more years of this at least. I still feel like that sometimes, but those first 2 weeks were fairly intense. There is no pill for this. Okay, there really isn't anything that makes it better. It usually resolves with social support. But that social support is absolutely vital, because if it doesn't happen, the baby blues can definitely progress to more of a clinical depression, and about 20% of the time they do. I know working in the safety net system, a lot of the women that I work with don't really have a lot of social support, and we really check in with them very, very frequently in the postpartum, and actually started a clinic in pediatrics because that's the one place they'll show up. They won't necessarily go back to their OB, or certainly not their own primary care doctor, but they will go for their baby to the pediatrician. So I'm interested to hear what Dr. Shervington has to say in a few moments about the role of the pediatrician. So what happens if she develops more of an actual like perinatal depression? Okay, perinatal basically means anytime through pregnancy and then up to a year postpartum. So in kind of the land of psychiatry, however, there's a very narrow window for when something can be considered postpartum. It's actually just 4 weeks after delivery, but that's not true. The vast majority of cases of postpartum depression actually begin in pregnancy, and then they get worse 4 weeks plus after the baby's been born. And actually suicide, which is the second highest cause of death for women related to pregnancy, actually, the most suicides occur from 6 weeks after delivery to 1 year after delivery. So my point in saying this is that psychiatry has it wrong. When the other piece that I think is really important to note is that, again, if you look at like some kind of diagnostic manual, the DSM, whatever, that, you know, that there's no distinction in perinatal depression from any other kind of major depression. Not necessarily true. And one of the reasons is this, okay? So here's a little pop quiz. So get your chart ready or your chat box ready. These are the symptoms of depression, okay? There's an acronym everybody learns in med school called SIG-E-CAPS. And in order to qualify as having depression, you need to have at least, I think, 5 of these for about 2 weeks. And these are the symptoms. Sleep disruptions, meaning you sleep too much or too little. Your interest declines. You're just not that interested in things that used to give you joy. You feel guilty, out of proportion for anything you actually have to feel guilty about. You have low energy. You have concentration that's quite poor. Appetite disruptions that are either too low or too high. So you're either overeating or just not hungry at all. The other P is for psychomotor retardation or agitation, which is a fancy way of saying that you can actually see depression in a person's body by the way they move. So if they're agitated, then they're very kind of like revved up. If they're retarded, then it looks like they're just walking through molasses. You can see that as soon as they walk in the room. And then of course, the final S is for suicide, suicidal thoughts, intent, meaning they want to do it or plan. But let's go through this, okay? So out of all of these symptoms that are characteristic of depression, how many are normal in a woman who's pregnant or just had a baby? So I'm going to put on my chat here. So type away. Which of these do you think are normal? All but SI. Okay, you're not far off. You're not far off. How about a few more specifics? Almost all of them. Yeah, okay. Sleep for sure. Sleep. Yep. Everyone knows that in pregnancy, it is hard to sleep. You're big. You have to go to the bathroom all the time. It's uncomfortable. Yep. Energy. Most people in pregnancy, particularly first trimester, when maybe you don't feel very well, and then last trimester, when you're just physically big, have much lower energy. Appetite disruption. Absolutely. So craving special foods or not being hungry, or when you're breastfeeding, just wanting to eat everything in sight. Concentration, yes. I think we've probably all heard the phrase mommy brain, which is, you know, not terribly respectful, but true. Psychomotor retardation can happen. Guilt, that's interesting. Yeah, you feel like you're just kind of always doing it wrong, especially if it's your first baby. Yeah, so if all of these things are normal, right, in pregnancy, then how do you tell the difference between someone who's just undergoing a normal pregnancy or postpartum period versus someone who's actually depressed, right? And there are a few red flags. So the main red flags that you would look for in someone who's pregnant that should tip you off that maybe they need some assistance is one, first and foremost, their mood. The definition of depression is someone who has severe low mood, feelings of hopelessness, or feeling very flat, disinterested, disengaged. That's what you look for first. The second is for a lot of women, they tend to channel their feelings inward to their body. They have a lot of physical complaints, multiple complaints, severe complaints, complaints when maybe the doctor works it up, they're negative, but the woman's experience is real of pain or headache or nausea or whatever it is. The third is anxiety. It is very, very rare that I see anyone who's depressed who's not also anxious in the peripartum. And then the final is disinterest in pregnancy, which actually almost worries me more than anything, because it means that mother, that expectant mother, is not forming any kind of bond or attachment to her child, which is a real risk factor for postpartum depression, as well as difficulties in that relationship moving forward. What's different postpartum? So a lot of the same things. So these are things that would tip you off between a mom who's just experiencing kind of a normal postpartum period, sleep disruptions, appetite disruptions, low energy, et cetera, and one that's really struggling with maybe with some mental health challenges. Anxiety, anxiety, anxiety. I cannot say it enough. Anxious, how much is she breastfeeding? Is the baby sleeping? Don't let anybody touch the baby. We're seeing this a lot in COVID because of mothers' fears of a child getting infected or having anyone come in. But what that does, I mean, it's totally understandable, but it can eliminate whatever social support she may even be able to access, which is already limited during the pandemic. Agitation, lack of connection to the infant. I had a mom come into me once about 9 months postpartum with her gorgeous baby boy that she was taking very good care of, and said she felt like she'd been babysitting someone else's child the whole time. And it broke my heart. And that is not any kind of formal symptom of depression that they teach you about in medical school, but it's very real. And then suicidality. We have all these public health campaigns around, all kinds of medical issues in pregnancy, and we forget that so many women kill themselves in the postpartum. So I said a moment ago, where there's depression, there's anxiety. It takes lots of different forms. Women can have panic attacks. Just so you know, like the kind of general prevalence of panic disorder in the general population is about 1% to 2%. That's the number of people who just have panic disorder in the world. In the postpartum, the number of postpartum women who have panic jumps to about 11%. So huge jump up. Obsessive compulsive disorder, post-traumatic stress disorder, which actually is defined perinatal PTSD as the trauma being childbirth itself, which I think is particularly applicable to the work that AIM is doing. Generalized anxiety disorder, and then just this idea of stress in general. Okay, but of course women don't come in and tell you these things, right? They don't give you their Siggy Caps list of symptoms. They say things to you, their lactation consultant, their doula, maybe their pediatrician, if they feel like you're listening. I don't really feel like myself. I feel like I'm on an emotional roller coaster. I feel numb. I thought I would be happy. I feel guilty. I'm a bad mother. This one is really a tip off for me. My baby doesn't like me. My baby likes everyone else more than me. No matter what I do, I can't relax. I can't sit still. Even when the baby's sleeping, I can't sleep. Insomnia is a huge red flag for postpartum anxiety, depression, bipolar disorder, all kinds of things. So if a woman comes to me and says, listen, my partner's asleep, my baby's asleep, the other kids are asleep, I know I've got at least a couple, 2-3 hours before I have to nurse again, and my body or my brain won't let me sleep, that is something that we pay a lot of attention to. Okay, for the sake of time, I'm actually going to kind of move past this section. It's probably the most important section, but the slides are pretty self-explanatory. And I want to leave time to kind of talk about the screening and the med piece just a titch. I put a picture of Kamala in there because I just am so excited. And I think the most fabulous social support right now for all women, particularly women of color and Black women, is that she is now someone we all get to look up to. Okay, understanding screening tools and red flags. So some of you may already be very familiar with these screening tools. These are the ones that are used largely in the county system. So Department of Health Services, Department of Mental Health, and the ones that we use the most are the PHQ-9, Patient Health Questionnaire 9, which is for depression. And it asks questions about the past 2 weeks. The GAD-7, or Generalized Anxiety Disorder 7, looks for currently clinically significant anxiety. And that's actually hard because kind of everybody's anxious. I mean, I think right now in this time of pandemic, we're all working off some anxiety. But the question is, when does that anxiety become pathological? When does it like impact your functioning? You can't kind of get your stuff done because of anxiety. That's what the GAD-7 is looking for. And then another thing that I'm really trying to implement in the clinics where I work is something called the MDQ, or Mood Disorders Questionnaire, which actually looks for mania, which is like the defining symptom of bipolar disorder. If someone has a manic episode where they're elevated, irritable, don't need to sleep, talk fast, think fast, kind of do stuff that's out of character that gets them in trouble, that's what someone has to have a diagnosis of bipolar disorder. And the MDQ looks at symptoms of bipolar disorder either currently or really anytime in the woman's past. The reason this is important is because about 25% of women who present with postpartum depression actually have bipolar depression. What that means is in bipolar disorder, by definition, you have to have a mania to have that diagnosis, but most of the time people are depressed, the other side of the pole, right? If someone shows up with the depressed side of bipolar depression, you can't tell it from regular depression. They look pretty similar. So we're really trying to encourage screening in our clinics for the MDQ for anyone who has depression so that we know if that's more kind of a regular depression or bipolar depression, because they're treated very differently. I can certainly say more about that. I just want this to be kind of a point of awareness, really, more than anything. I'm going to just leave this be. This basically shows the kind of cutoff screening points for the PHQ-9 and GAD-7, what to do when you get them, and basically anything above 10 on either scale is positive. 10 to 19 is concerning and there needs to be some treatment, certainly therapy, potentially medication, and anything above 20 is highly concerning, certainly needs some psychiatric intervention. One thing that I would really emphasize is that if you do start screening, you know what to do if you get an answer that's scary. Okay, I just feel it's so important to be prepared, right? And the scariest thing that you're going to hear from someone who's postpartum or pregnant, but particularly postpartum, is that they want to kill themselves or hurt somebody else, right? So if someone scores a positive on that suicidality question, which is the last question on the PHQ-9, question number 9, like it says here, then there are a few questions you ask. In the past few weeks, have you ever wished you were dead? Have you ever felt that you or your family would be better off if you were dead? Have you had thoughts about killing yourself or how you would do it? And have you actually tried? If the answer is yes to any of these, it's time to seek help. Whether that is walking the patient to a social worker or a psychologist or psychiatrist, if you're in maybe an academic center, it means calling the DMH access line if you're in a clinic out in the community, but it means knowing what to do if someone answers this question with a positive answer, they answer then yes to one of the questions you ask, then you know what to do to act on it. Same thing with infanticide. And I hate to be like, my husband laughs that he can't take me out in public because my job always kills all conversation. But basically, infanticide happens in a very, very small percentage of women who suffer from postpartum psychosis, which is a whole other thing that we'll talk about a whole other time. But basically, have you ever had any thoughts of harming the baby coming? Have you ever had thoughts of harming the baby, either accidentally or by your own hand? And a lot of times I'll normalize that in the postpartum and just say, listen, this question might seem odd. but it's something we ask everyone. And if she says no, fine. If she kind of hesitates or says yes, then you need to kind of go down that same path of having her assessed behaviorally. Postpartum psychosis only happens in 1 in 1,000 deliveries. It really is kind of a manic episode, like I discussed previously, but it certainly can happen. And we just, again, it's like you want to know what the worst case scenario is, hoping you never actually encounter it. Okay. These are just some phone numbers: psychiatric ER, 911, DMH access line. Okay, so I'm going to talk very briefly, I think I have like 6 minutes, about the medication side of things. And first thing I want to emphasize is that by no stretch of the imagination does every woman or every birthing person with a maternal mental health disorder need medication. Not by any stretch of the imagination. Only about 20% do, and of that, a certain percentage might not choose to take it, or really actually don't even need to take it, but it's a very small percentage. But again, I want you to be aware of how to think about it and what to advise patients about it, because for those who need it, they typically really need it, right? There are so many other ways that maternal mental health can be addressed. The most important is probably, again, the social support and often psychotherapy, which can be individual, and then group therapy or support groups, which is one thing AIM is actively working on. For a lot of women, family or couples therapy, because maybe it's the relationship with the father of the baby or their mother or whoever that's causing like a lot of the stress that's leading to symptoms. For a lot of women, they need kind of lifestyle changes, maybe cutting down on caffeine to help with anxiety, or getting some exercise, which has really been shown to have an effect on mood. And everybody needs psychoeducation, that this is not something to be ashamed of. This happens, for families to be supportive, for women to be able to ask for help. If a woman does need medication, there are certain things that I go over before we even start talking about it, because as a woman who's about to give birth or who's breastfeeding a baby, no one wants to take medication. I think in my entire career, I've had like one person who wanted to take medication, and that freaked me out. And I had to really think about why she wanted it. When I was pregnant, I remember doing extensive research on like Tylenol before I would take it. So I fully understand how scary this can be. The primary kind of message that women get from really everyone around them, including themselves, is that if you take a medication, you are actively doing something and it might hurt your baby. Whereas if you choose not to take medication, then you're not really doing anything. And so it would not be your fault if something happened to the baby. So it's the guilt that would come with thinking that you're a bad mother if you prioritize your own well-being. And a lot of that comes out of fear that medication will hurt the fetus or the baby. A belief in a lot of women who are pregnant that after the baby comes, they're going to be fine. And some are, but the majority are not. There's a lot of stigma around med use, that people who use medications are weak, and you should be able to pull yourself out of it, pray your way out of it, just work a little bit harder, which, we don't tell someone who has cancer or diabetes. There's this fear too that medications are going to fundamentally change a person's personality. And I usually talk to patients about the fact that they don't, they just get you back to being who you are. You're still going to have good days and you're still going to have bad days, but you're going to at least be back to feeling like yourself. There's a fear that anything somebody takes for any kind of psychiatric reason is addictive, right? And there are some meds that are addictive, but we very clear when we talk about which ones that are and which ones that aren't. And of course, misinformation, which tends to come from the internet or often very well-meaning family or friends or even healthcare providers. My job, and what I would hope would be the job of other folks who are prescribers here, is to really help the individual person who's giving birth to think through risks and benefits, right? There is no clear-cut answer. Yes, you do this. No, you don't. At two different people with the same history and the same symptoms, when presented with the same information, may make very different choices. And that is totally okay. But I do very strongly believe that every woman who's planning a pregnancy, is pregnant, or just gave birth has the right to all the information that we have so that she can be empowered to make her own choice. So my main job is actually as an educator. There are a lot of effects of perinatal mental illness that, if it's untreated, can be very harmful for the pregnancy, the delivery, the newborn, and the mother. And this is part of the risk-benefit conversation that often doesn't happen, because historically, healthcare providers have been very hung up on the meds as the problem. But what we have more and more evidence around is that it's actually that risk for medication needs to be weighed against the risk of having an illness that goes untreated. So these are some of the things we see. Difficulty adhering to prenatal care or med regimens, like let's say you are diabetic with a complicated regimen. Much harder to do that if you're severely depressed. Substance abuse becomes much more common. In particular, we are seeing so many women now use marijuana to treat anxiety and insomnia. We don't know the effects of that. Preeclampsia can happen with untreated anxiety and depression, as can suicide. For the infant, low birth weight, preterm delivery has been associated because of a lot of those same toxic chemicals that Brandy was talking about earlier, very much connected, as well as cognitive delays and behavioral problems. One thing to note, I have like a minute. Okay, very quickly. One thing to note is that the FDA system of categorizing medicine by safety based on A, B, C, and D is basically meaningless and is no longer used. Okay, I want to say that because it's really important, because I know a lot of doctors lean on that to help kind of make choices around medicine, but it actually isn't helpful at all. The reason why is because category A means totally fine. There are basically no meds in that. Category B means that there's no data that the medicine causes harm to a human fetus or a lactating baby. C is that there is some evidence of harm. So every new medicine that goes out on the market is given a B category, not because there's no evidence that it doesn't harm the baby, but because there's no evidence, period, because these drugs are not tested in their development on pregnant or breastfeeding women. So new meds get put on the market, everybody switches to them, and yet we have no data on them at all. So the categories have been switched. We now have 3 kind of subsections for newer data, one about pregnancy, one about lactation, and one on how the med potentially affects the reproductive potential for both males and females. And so that data is not telling you yes or no, it's giving you information that then you use in clinical decision-making. For meds, there are 5 areas of potential risk, okay? Not every med causes risk in all 5 areas. Some meds don't cause risk in any areas, but I kind of mentally go through what I know about the risks in each of these areas when I'm prescribing something, and then I know I've covered my bases. The first are first trimester concerns, primarily birth defects or miscarriage. The second is prenatal management, like does this med increase the risk for weight gain and high blood pressure? The third is concerns around delivery. Does this medication cause problems in the neonate in terms of, let's say, respiratory distress? The fourth is breastfeeding. Can the mom safely breastfeed with this? And the fifth is any long-term effects, like is this child going to have a higher risk for autism or developmental delay? The vast majority of studies really don't show elevated risk much at all. And so the question to really ask, and I'm just going to do 1 or 2 more slides, I swear, is whether or not the medication you're thinking about giving a pregnant woman or a breastfeeding woman, does it increase the risk of a particular condition, like let's say diabetes, above the risk already present in the general population? These meds don't cause anything new, no new syndrome that like doesn't already exist, okay? A great example is actually the question of whether or not antidepressants known as selective serotonin reuptake inhibitors or SSRIs increase the risk of birth defects above the general population. The rate of birth defects for anyone who has a baby, regardless of who they are, is roughly 2 to 3%. SSRIs, after many years of study, with one possible exception of paroxetine, do not increase the risk of birth defects above 2 to 3%. Okay, so that's the kind of question that we ask and that we advise women about. We use the kind of standard chart that everyone would go through, and this is an example of how I would fill it out for SSRIs. I'm going to stop. I'm going to go just show you what the next slides are so you know kind of what they are. I tried to make them very, very practical if you're an MD and you want to use these moving forward. Basic guidelines on using antidepressant management in perinatal women, in particular SSRIs, because these are considered first line. In general, if a woman's already on an SSRI, you keep her on it. If she did well on it before but stopped because of pregnancy, restart it. If she's new to an SSRI, we generally begin with sertraline or Zoloft and go up until her symptoms are controlled. If that doesn't work, the second line would be escitalopram or Lexapro. Same thing, titrate up till it works. If it doesn't, after 2 trials, it's probably time to go to psychiatry. This is a chart of the different meds with doses available, therapeutic dose, usual dose, starting dose, etc. These are dosing strategies for the 2 meds I just named. Breastfeeding and psychotropics, I always ask about this very early in the game. One of the most important things to remember is that any breast milk a mom can give is great. If she needs to take medication to stay stable, or she needs uninterrupted sleep to stay stable, it's okay to mix breastfeeding with some formula feeding or expressed milk feeding so that she can preserve her mental health. This is where all the pediatricians don't like me, but it is really true. There's also a wonderful website by the NIH called LactMed, and I put the citation down here at the bottom. That's my go-to. It has every med you can think of, psychiatric and non-psychiatric, even street drugs, and the effect that it has on breast milk. Super helpful. And then this is when to refer to psychiatry, right? This should make total sense, right? Bipolar disorder, really high scores on a depression or anxiety scale, or a positive score on the one for mania, any kind of psychosis, anxiety that feels unmanageable, co-occurring disorders such as opiate use disorder, methamphetamine use disorder, and any kind of mental illness. And then if they haven't responded to the 2 trials of an SSRI, or if they want to see a psychiatrist, which never happens, but one can hope. And that's it. So that's my email address. I am with DMH. I am always happy to answer questions, anything from specific meds to resources, etc. DMH is a slow-moving ship, but I am trying hard to get women's health more in the forefront of the services that we provide. So I'm going to stop for the sake of time, but am more than happy to answer questions at the end. Thank you guys very much.
Thank you, Dr. Dossett. I think we'll move on to Dr. Shervington.
Hello, everyone. I think I was so caught up in Dr. Dossett's presentation that I forgot I was up next. It is such an honor to have been invited to present to such an esteemed group. I am also honored to follow Dr. Dossett because a lot of what she said, I can really just skip through. I want to thank Dr. Carlisle for inviting me. I know I have a few friends in the audience. I know I probably need to join the association. I'm just settling into Los Angeles, so I'm excited, and thank you for all the great work that you're doing to keep our professional development going. I am going to share the screen now. Let's see if I can do this. Great. And so, I'm going to be talking today about the role of the pediatrician in promoting maternal mental health. And as Dr. Dossett said, and in particular, Black women, we'll turn up for children oftentimes much more than we turn up for ourselves. So I think that as pediatricians or anyone who is really working with us, that there's such an important role to help us to modulate and manage our mental health. My focus, however, is going to be less on mother and a little bit more on child. But then also remember that mother herself was a child. And so some of the issues that might be happening when she is a new mother is a triggering of issues that she's had since childhood and throughout her life. And just want to remind us that, we're born helpless as a species. And without a parent's very kind and loving attention to us, to help us to develop, it is really, really difficult to survive. We know that without touch in the early years, there can be a failure to thrive. And there have been even some cases when it was so severe in the early years that the infant died. So, as was said, and I'm going to quickly go through some of this, but I just had to center mother here, is that, the most undiagnosed obstetrical complication is peripartum and postpartum maternal mental health issues. As disabling as the condition could be, if treated, it can be very helpful. As Dr. Dossett showed the data for LA County, I looked at one study that looked at the national prevalence was that 10% of women will experience depression during pregnancy and postpartum. And when it's looked at nationally, which is really interesting to me, based on this study that was done, and I have the reference, that the majority of the women who have clinical depression tend to be white and Native American women. However, depressed and Black and Latinx women experience much more adversities, have worse functioning, and are less likely to receive treatment when they are depressed. Again, that was mentioned by Dr. Dossett really very quickly, that about 20% of women will have depression, and through the first year, 13% continue on for 2 years, 40% are going to relapse with subsequent pregnancies, especially if they were not treated. And as was underlined so beautifully, was that women tend with their depression to have severe anxiety and at times panic attacks. And of course, the mention was made about psychosis. I actually, very interestingly, you mentioned infanticide. I am currently seeing a woman now whose the infanticide happened by the husband. The father killed the infant. However, and he's locked away in prison, as you can imagine. She then had another child, and in the first 3 months in particular, after the second baby was born, she was really, really worried that she perhaps could kill her child, having had the experience that totally traumatized her of her husband killing the child. The contributing factors we know are the changes in the reproductive hormones that affect the GABA receptors. We also know there might be genetic factors. Also, women who have a pregnancy that ends with the NICU, that they're more likely, the stress of the baby in the NICU. And I just had a new grandbaby, and he was in the NICU, and I definitely saw some changes in my daughter-in-law. So just to remember that this makes women very vulnerable, dealing with the stress of a pre-birth child. And also the social factors, and this is where Blackness comes in, financial difficulties. And maybe because we are more, as Black women, more used to not having enough resources, the data shows that when that's so for white women, that is particularly more challenging for them. And then the issues of domestic violence, substance use, and any negative effect we know can contribute to maternal mental health challenges. I'm going to skip this. That was nicely covered by Dr. Dowsett. Just really, what is the cost when we don't treat maternal depression? The data that shows that there are increased costs for medical care, unfortunately, inappropriate medical care, inappropriate diagnosis of what's happening. And what I'm going to focus a little bit more on, because I'm speaking to pediatricians among you, or just anyone interested in the child, and even if you're OB-GYN or whatever, I'm sure you're interested in this woman and her child. So the possibility of child maltreatment, abuse, neglect, and the discontinuation of breastfeeding, or just challenges with the nutrition for the child, and then with untreated mental health conditions within a family unit, we can have a lot of dysfunction. So I'm going to go to my favorite subject, the child. As I mentioned earlier, children cannot survive without their caretakers. And in particular, as humans, we are very predisposed to form attachment relationships, and starting with our primary caregivers. Now with the pandemic, we're beginning to understand how important social engagement and touch is, as we've had to spend this year really in this predicament of being disconnected from our communities and those that we love. Winnicott, pediatrician and analyst, talk about the good enough mother who provides the attunement and the nurturance and the attention and empathy that a child needs to really help them to hold and bind their anxiety. The good enough mother helps to mirror and reflect an infant's self-worth. She facilitates and applauds the achievements as the tasks become more difficult, and basically is helping the infant and the child make sense of this world, their inner world and their outer world. Just quickly put up here the developmental needs, in particular in the first 3 years. If you ask me what we could do to resolve a lot of social issues and health issues, I would say, let's copy what some civil societies do and give parental leave. In Canada, I know it's up to 18 months. In Scandinavian countries, it's a year, because it is so important, the nurturance and bonding that happens between an infant as they're beginning to hatch out into this world that's so foreign and alien to them, leave that nice, warm little pouch that they were in, being cooked for 9 months. And I'm saying that because I have a really new little grandson, and sometimes it seems like he'd rather just go right back to where he was. And so how important it is for us as a society to support in the first 3 years the ability and availability of parents to really bond with their children, to allow them to meet those developmental needs in which they will trust that the world is safe enough for them, that they will have a presence, that they will be seen because their needs are being attended to, that they begin to learn about their own autonomy. They are initially made to feel omnipotent, and sadly we learn over the developmental course that we have to let go of that, but you needed to have that sense of being the center of the world so you can let it go and just become one in billion. And they learned the sense of their own individuality and their autonomy as they begin to learn to separate from their maternal object. And again, I know there's language. I'm going to say mother, but I mean anyone who's caretaking and for whom it is the primary task. And so when attachment is good enough, the infant, the child, has someone they can turn to when they feel distressed and in need of soothing and protection. They feel more comfortable exploring the world, modulating their emotions, exploring the unfamiliar. And very importantly, they learn how to be alone because they've had enough nurturance in that bond. And for those of you who work with young kids, you know, that preference for attachment in the early months, the infant will attach to anyone, but starting about 7 to 9 months, the infant begins to want to have a primary attachment or more than one primary attachment objects. So I mean, if you're just thinking, I just want you to be carrying along my presentation, what happens when mom is dysregulated, when she has some kind of a mental health condition. We know that within this attunement, this positive attachment, it helps to shape the architecture of the developing brain. I think reference was made earlier to that by Ms. Sims. And now we have enough evidence that shows that the attachment, the quality of the attachment in those early years between a child and their caretaker is a very strong predictor of psychological and social outcomes. And one might say health outcomes through adolescence and lasting, as the adverse childhood experiences study has shown us, really lasting throughout the life course. I think I have mentioned enough about attachment. And just want to, for those of you who are working with kids, because I think in terms of your role and your charge to be really attentive to maternal mental health, you can see sometimes what's happening in terms of the emotional landscape of the maternal object in a child's life through actually how that young child is behaving in terms of how they are showing you their early behaviors. If you see a lot of ambivalence or they seem very anxious and insecure, as you assess the relationship that mother has when she brings the infant in. If a child is very, very, very clinging, getting very, very distressed upon separation and cannot be soothed. If when the maternal object comes back and the child is very demanding, is much more interested in being connected and attached to the returning mother versus exploring their world, you can begin to sense that there is something happening in that maternal child bond. And the possibility is that mother might be having some challenges with her own mental health. So as pediatricians or those who care for kids, you're in a really, really good position to assess that there might be something going on with mom. And of course, the most extreme kind of attachment trauma, which usually happens when the caretaker for the child is very frightening due to how their mental health disorder or their substance use disorder is impacting the child, then you are in a position to begin to say, I need to do something to support this mother. Why that's so important is that if the child does not have this safe haven, this nurturing, loving space, they then begins the cycle of developing mental health conditions. So this child cannot have a very coherent sense of who they are. It's difficult for them to mentalize because we begin to learn how to understand our mental landscape and the landscape of others through the interaction with our caretakers who are helping us to understand our feelings. What does it mean if something hurts, that you're sad or you're afraid? We learn that language in our interaction with our caretakers. We also learn to modulate our emotions through that loving bond and the soothing that happens when we feel negative emotions. And most importantly, it is in that bond that a child learns how to be resilient, how when bad things happen, and they will, how to be able to effectively cope and come back better from learning from that experience. And when we cannot cope with traumas, as was earlier said, then there are significant neurobiologic consequences. We're constantly living with our stress hormones activated, which then makes us so vulnerable to illnesses. I want to talk a little bit about trauma because it's oftentimes we now know that trauma happens oftentimes within the bonding that happens in the first 18 years of life and usually starts in that early attachment with mom. And just because the word has become so commodified, so trivialized, at the clinical level when we're talking about trauma, it is really an external event that overwhelms a person's coping and activates the neurobiologic stress response that's necessary for our survival. Want to reference the adverse childhood experiences study that was done, because we have an opportunity, especially pediatricians, and anyone, again, working with children, have such an opportunity to play a role in addressing adversities, not just in the child, but also in the mother, which perhaps is a source of her mental health conditions. So as was done in the study, and I'm sure everyone here is familiar, I'm not going to go in details, really is that if before the age of 18 years, a person was exposed to or experienced physical, sexual, or emotional abuse, or neglect, emotional or physical neglect, or they grew up in a household where a caretaker had substance use problems, mental illness, like we're talking about what can happen in maternal mental health. If there was a suicide attempt, intimate partner violence, domestic violence we tend to call more here, or parental imprisonment or incarceration. And this is a conventional ACEs study. Philadelphia, and now been adopted by many other cities where they have a much more diverse population, because the original ACEs study done at Kaiser Permanente in San Diego was with a very white population, highly educated population. So Philadelphia expanded those questions of adversity, and other cities have adopted that, where if you've also witnessed violence, experienced racism or discrimination, living in an unsafe neighborhood, usually that's because there's a lot of violence, experiencing bullying, or lived in foster care, that you're more likely, as you actually during adolescence, much more likely to engage in risky behaviors, unsafe sexual practices, and substance use. And then, as you know, there's a graded response based on the adversities. up to having experienced 6 ACEs, where you're much less likely to die than someone with no ACEs. And these conditions tend to be cardiovascular, they tend to be depression, substance use, and suicide attempt. So we also do know that the trauma can impact the epigenetic expressions, and now there's evidence of impacting telomere length. And so, which makes, to me, I just want to highlight the issue of intergenerational genetic transmission of trauma. So as we're thinking about what's happening with mother, that probably happened with grandmother, that happened with great-grandmother, and now is happening with the child. And why this is so problematic is that why as pediatricians you want to be concerned is that the neurons really show the greatest plasticity during the first 5 years of life. And so anything that's happening in the infant and child's early life can very much influence what happens later in terms of their mental health and their physical health. So this mother that we're seeing who is now endorsing symptoms of depression or anxiety or PTSD and is now in an interfacing with a new child, that it's likely that we're seeing intergenerational transmission. There's an interesting study that was done at Tulane that showed that higher maternal ACEs, so they screened new mothers for their ACEs and found that this was associated with shorter telomere length in the infants, and also that at about age 18 months, they were beginning to see the infant externalizing much more behavioral problems. So I hope I've set it up that for those who work with children, maternal mental health is so, so very important. And also remember that mother herself was a child, and what was the environment in which she was raised. And when studies have been done, asking pediatricians about how they see their role, given that mothers will turn up more to see them than perhaps any other of their care dividers. The challenges that they've endorsed really is in the recognition and management of mental health conditions. They cited and looked at 2 studies that basically said that pediatricians feel they don't have enough time for even their own what's considered the pediatric history, much less that of the mother. They don't have enough time to do the education and counseling. They also have not had enough training to really feel confident with a diagnosis and what the counseling route is. I'm very, very happy that Dr. Dowsett, I hope I'm not mispronouncing your name, that she really laid out the framework for how to recognize and know what to do, when you should refer, when you can treat. And also, let's not forget that the healthcare system is also very fractured, makes it difficult, especially around getting the kinds of referrals that's necessary, and sometimes just the stigma. I think I heard mentioned Dr. Dossett talked about a collaborative approach, working with pediatricians and psychiatrists and OB-GYNs, and that's really exciting, and perhaps how we're going to address some of these issues. However, we really do need pediatricians, as they are oftentimes willingly or unwillingly the medical home for the child, and at times by proxy mom. We need to be able as a healthcare system to develop systems of screening, whether it's done collaboratively with mental health professionals. And then in addition to the screening and knowing what the limits are to treatment, being able to know what those referral spaces are in the community, and not just for the medical component. And I'm very happy to be followed by my colleague talking about the community perspective, but also, what is there in the community that can really support parenting and the mother-child diet so that there can be healthy attachment within that relationship. And really quick, I'm sure many of you are very aware, and I'm just going to mention it, our Surgeon General's efforts, the ACEs Aware Program, to screen, treat, and heal ACEs. And what's great about it, I have the screeners up here. What's great about it, is that there's also an opportunity for the person treating the child to also screen mom. There's at least 4 ACEs. And then within that, if mom is presenting with having had a lot of exposures to adversities, the chances are that she's going to need mental health supports, again, along the same trajectory that was described by Dr. Dowsett, from needed maybe just psychosocial supports to when you have to refer for a higher intensity of clinical care. I wrote the principles of trauma-informed care that every physician can begin to use, that basically knowing how to recognize signs and symptoms of trauma, how to create safety in the practice, how to build trust between provider and the patients you serve. I think nowadays we're very aware that we need to be patient-centered, have mutual treatment goals. We have to pay attention and really look at inequities and how the cultural sensitivity of those that we serve, people take it all the way out to humility. I just basically say how to be respectful to all humanity, and also not to have our practices be spaces that are re-traumatizing. So be non-judgmental as healers. I have summarized here the program, the healing component. I showed you earlier the screeners. It was been said by Dr. Dowsett before that, we need to educate all the folks, with any Black person I'm saying, and Black and brown person, that we're seeing about how to regulate stress. Racism is a major source of stress in our lives. And so how we recommend that we really try to have healthy and supportive relationships, have a community that we can rest in, where we feel safe, and at the more individual level, the need for sleep, nutrition that's balanced. It's important to challenge the diets that many communities of color are engaged in, and especially the less socioeconomics we have, the food deserts and exposure to certain extremely unhealthy foods. Part of helping any person we work with is helping to support their mind ability for mindfulness and meditation, which is to just slow down the monkey minds that we all have, and have periods of rest and solitude, meditative moments in our life. And oftentimes, as women of color, we're running, and we don't have time to stop and attend to ourselves. So what does our self-care? I feel every physician should ask every woman, what does your self-care program looks like? And it oftentimes is not activities, it's how are you managing to move closer and closer to who you truly are and find meaning in your life, being present in your body and with your mind, so that you understand how best to care for it. I think I'm going to end now to say that mothers do not exist in vacuums. Children do not exist in vacuums. In fact, none of us, as we are social beings, we need each other, and the role of the physician in helping those of us who might during a very vulnerable period, biologically or socially, when we're in the process of childbirth and child rearing, that it's really, really important for us to be able to understand what those signs and symptoms are when we become dysregulated and know how to manage and treat. So I want to thank you very much and look forward to our next speaker. You stop sharing.
Thank you so much, Dr. Shervington, and please place your questions in the Q&A for Dr. Shervington and Dr. Dossett. And now we'll move on with our final presentation by Ms. Winona Valentine.
Good afternoon, everyone. Again, my name is Winona Valentine, and I just want to thank my colleagues, Dr. Dossett and Dr. Shervington, for really providing a foundation of what we are working with outside of when we go into the clinical arena. When we're in the community, we have just a huge way that we look at Los Angeles. And particularly I say Los Angeles because unlike any other cities across the nation, that I like to describe it now as you can travel from San Diego to the top of the state through the 5 freeway. But when you come into Los Angeles County, you are now encountered by the 405, the 105, the 110, the 10 freeway, the 118, the 210. There are many pathways that we call community that's very unique and specific to Los Angeles County. And as a charter member of the AIM Steering Committee, it's my opportunity today to really give a sense of how we as Angelenos are navigating through the disparities of maternal mental health and really give a perspective of how the community's voice is really a part of what I love, Dr. Shervington, you just said, a community we can rest in. Oh my God, that is so powerful because so often we don't think of our community as a place of rest. And my hope is that with our AIM initiatives, that we're bringing a whole different dynamic in the way that we're, the way that we're connecting. So, in preparing for today, I had to really reflect on that 2020 was really a amazing year in the sense that I had 27 external speaking opportunities. And it was a continuum from pre-COVID, face-to-face through virtual. And today is the 27th talk. And it gave me an opportunity to reflect on the discovery and the exploration that really was a gift of being involved in critical conversations. And those conversations included university, undergraduate and graduate students, medical residents, clinical practitioners, clinical leaders, hospital quality improvement initiatives, medical maternity providers, health systems, health plans, and among my peers who have, Black-led and Black-serving organizations. And what I discovered in these 27 talks was that there were 3 main pivots. One is that it really guided iDream's anti-racism statement that we released in June 2020. It also informed that by September that we had a board adopted commitment to a justice-led vision for 2025. And it confirmed iDream's leadership for readiness, growth, and development as a pathway for movement builders. So with that, I just thank you for the opportunity to allow me to be a thought partner. The honor is mine to be able to share our storied mission with lived experience and social service insights. I'm going to read this quote for the recording, and it was a quote that one of our ABWP members had offered in the focus group in May of 2021. And it reads, physicians share in the experience of racism similar to the very Black women who are their patients and are able to communicate about the role of systemic racism and disparities while not disregarding individual behaviors. This quote was very important to me because when I think back on the timeline that it was Dr. Swilly, it was December of 2019 that you had reached out to me and to really start thinking about how we can have a partnership. The conversation started around implicit bias, but what we were able to do was to really form this partnership and to really listen to you as physicians, as a physician group, help me to really understand and focus in on this quote that we who do the work are also the patients that are involved in this work. So let me begin with giving a story about how the pandemics have really influenced the work that we're doing. I often, well, I should say, let me back up, is that we have at the beginning of the pandemic, we were thinking about, okay, so now we have to change the sheltering at home, and we're gonna have to make sure that we social distance ourselves. But this came during this brewing awareness that last year was the 400th anniversary of the of racism in this country, when the first Africans were enslaved and brought to Jamestown, Virginia. And so as a result of that, for Black Angelenos, we had a double hit around community grief. We were just overcoming the murder of Nipsey Hussle on March the 31st, 2019. And that wound opened up with the untimely death of Kobe and Gigi Bryant on January the 26th, 2020. And we simply were not prepared for the public sidewalk execution of George Floyd on May the 25th, 2020. So when we think about two pandemics, we're talking about grief that's happening in our community, and I'm specific to Los Angeles community, and we're talking about the social unrest that was sparked by Mr. George Floyd, and it became a global unrest. Then we were shoving this grief into the streets, and we saw that. But also what it did, it made me think about the heaviness on Black pregnant, childbearing, and postpartum birthing families. So we know that, and what we have adopted with the AIM initiative, that 400 years is enough. So by exploring what has happened in these past almost 12 months, it's on our watch now to ask different questions about maternal mental health. And my focus is on the women who do the work, or the birthing, or the people, the Black people who do the work. It's important for me to understand that our objectives are to rethink community-led approaches to systems change, and to ask different questions and seek guidance that earns safety and community trust. So there are a set of questions that I want all of us to think about that I'm going to read for the recording. And it says, in light of that new information, I have changed my mind. Oh, I didn't know that before. I guess I was wrong. From the evidence provided, it appears that I need to rethink things. You make a strong argument. I'll consider what you said. I can't support my opinion. I don't know why I think that. I never thought of it that way. Thank you. Now I will. So our first charge for today is to ask different questions. I want to introduce you to a collaboration called the Improving Outcomes Project that iDream has had the opportunity to take a lead role as the Black-led, Black-led organization that is interested in making sure that we have two different sets of deliverables, one to medical maternity providers and the other to support a group experience around peer learning. So the maternal mental health now goal in the Improving Outcomes Project is to improve the rates of detection, education, referral to treatment for perinatal mood and anxiety disorders among Black women in Los Angeles. So why iDream? Well, as it turned out that iDream was a presenter for Maternal Mental Health Now, excuse me, Maternal Mental Health Now conference in 2017. And we had the opportunity to beta test our workshop. And the workshop initially was called Adolescent and Maternal Trauma Informs a Life Course Perspective on Perinatal Mental Health and Black College Graduates. Now, I know that was a mouthful, and for me, that was my first abstract to be able to present at a mental health conference. But we were able to beta test this and really drill down that what we're talking about is the hidden triggers of race, and I'm going to say racism. We didn't say that in 2017, but I'm going to say the hidden triggers of racism, stress, and the mental health of Black college grads. This made this work very personal, and it links back to the release of the documentary Unnatural Causes, and episode 2 focused on When the Bow Breaks. When the Bow Breaks offered a statement that still rings true from 2008 to now, and that is that Black college grads have worse birth outcomes than white women who did not complete high school. So when we took this beta tested conference experience to UCSB, which is my undergraduate alma mater, and partnered with a faculty and a staff member, we were able to also include younger, or I should say intergenerational alumni. And we talked very candidly about implicit bias and microaggression that's happening with them in their early career and how they are navigating through the pressure that is impacting the way that they're showing up, feeling that they're enough, feeling like, oh, maybe I have failed, but in fact, understanding that this racial cloud that has hit over our early career professionals is something that we are impacted by throughout our working lives. So we also offered the second year in 2018, we were able to come back and we were offered I'm sorry, I'm going to take a drink of water because all of a sudden I need some water, excuse me. We offered a deeper dive called Value Us, Black Mothers are Subject Matter Experts for Improving Maternal Health and Birth Outcomes in Los Angeles County. So it was really important about both of these sessions is that there was a young journalist who came, who was inspired by our talks. So, excuse me, the breakout session that we offered in June 2017, it launched the career, the investigative journalism of Priska Neely, who reported on Black maternal and infant health in Los Angeles County. Now, why is that important? Because often when we hear data, we hear about the state of California, we hear national data, but particularly here in Los Angeles, the social determinants of health, of where we live, where we work, where we worship, and where we play, there's oftentimes you are not able to see the Black community just by driving around. So we choose to work in and to connect with each other through the vast landscape of Los Angeles. So we find meeting where we worship, where we work, where we shop, where we choose to have our entertainment, is where you find Black people in Los Angeles County. So the next piece here is that this journey really informed our commitment as an organization. And we're really focused in on a learning community of visionaries. But after the George Floyd murder, we really wanted to make sure that justice really led the way that we do our work. And it's important to understand that for us, healing justice means that we're not only just looking at the healing that's happening in our community at large, but we who do the work, we who are expected to put our feelings to the side, that we need a safe place and a safe community. And again, Dr. Shervington, just making that statement that we need to be a community of rest. I dream as a community that our network can rest in. So our why for the work that iDream does, I think, is best expressed by the late author Toni Morrison. And she wrote, "I didn't want to speak for Black people. I wanted to speak to and to be among them. It's us." So the first thing I had to do was eliminate the white gaze. This is so important for iDream because we have decided that we are not concerned about what's happening on the outside, how people view us. We want it to be a place where we're able to express how from the inside out that we're able to have a community of rest, that we're able to speak to the issues that are unique to not only our generational workforce that we're working with or the parents that we're supporting, but we really wanted to understand that the work that we do has meaning. So we draw our citations from Black scholars. We draw our support from Black clinicians. We try to look at and support how we are a part of this continuum that's going on without thinking about, am I a failure? Am I too loud? Am I too much? It is important that we looked at and we made that commitment when we first started in this contract with Improving Birth Outcomes project, I'm sorry. So our model is based on cultural humility. So doctors Melanie Trevelyan and Jan Mary Garcia really came up with 4 different arenas that informed what cultural humility looked like. So when you think about that, you think about this self-evaluate into self-critique, and that means that for the physician or for the medical provider is to be able to sit back and not be the expert, but to really begin to build a safety net in communication. Is this a safe place for me to be? Are you making this journey with me safe? This is a very important beginning. And what we found is that to focus in on our medical maternity provider training around cultural humility, that change fatigue and compassion fatigue are the first pieces that we focus in on. Secondly, we look at redressing the power imbalance and the patient-physician dynamic. So we really offer a foundation around generational learning. Again, we look at developing mutually beneficial non-hierarchical relationships with community members. So community wisdom is central to the way that we do our work. And finally, we look at creating institutional alignment and accountability. That comes from many of the initiatives that iDream is a part of, but also it's part of the way that we're doing this work now from the inside, meaning from hospital quality improvement programs to the outside as community being very much a part of what that model looks like. So make sure that if you're not end of my presentation, where you not only will be able to read the peer-reviewed article that they had written in 1998, but you'll also be able to see a video on what that model looks like. The 2 interventions that iDream leads with the Improving Outcomes Project is our interprofessional education, and it directly responds to SB 464, which is the Dignity in Pregnancy and Childbirth Act that became effective on January 1st, 2020. And we take the implicit bias umbrella and we look at the approach of cultural humility. What I like to say that we have shifted the conversation from IQ to EQ, and we offer an emotional intelligence skill building experience. The second is on safe and sacred pregnancy, which really is a program that we developed the outreach and marketing approach for. It was a curriculum already that was sustained in the Improving Outcomes collaboration, and it directly responds to AB 3032, which is a hospital maternal Mental Health Act. And what that does is it requires all birthing hospitals in California to provide education and information to postpartum people and their families, and that all staff, labor and delivery staff in particular, must receive this education and information as well. In the Safe and Sacred Pregnancy, what we have discovered is that in order to create, to build community for pregnant and postpartum families, that we wanted to provide an experience so they're able to come to this 4-week series with a support person. So that could be their partner, that could be a grandmother, it could be a friend, whoever can challenge, who can come with them to this arena. I don't know why I'm nervous. Everyone who knows me on here knows that I'm not nervous, but I am today. Okay, another central feature for us is storytelling. When we are presenting, we have the opportunity in our work is to tell a personal story. I'm going to tell one that's very brief. And when I was a 19-year-old pregnant undergraduate, I started my prenatal care in Santa Barbara. Again, I was a student at UC Santa Barbara, and I was aware of the fact that the physician who saw me in my early prenatal care just did not give me the support that I needed. I saw myself as a student of promise. I saw myself as a student who was not only continuing the pregnancy, but also found that the university was offering me support. So I was able to make a decision, and I traveled from my 2nd and 3rd trimester to Los Angeles on the Greyhound bus from Santa Barbara to Los Angeles for my prenatal appointments so that I can be served by a Black doctor. And my son was delivered at California Hospital, and he had a Black pediatrician. So when I think back 46 years ago, I look at the fact that my journey around advocacy and standing up for myself is really the trajectory that I've been able to bring to this work, and how we're able to make the work very personal. And what we have decided in our storytelling is that we have this theme in cultural humility is, what if the experience is the outcome? So here I'm just going to introduce the team to you. There's just 2 slides to just show you who our interprofessional education team is, and our Safe and Sacred Pregnancy ambassadors are. We are really the heartbeat that helps us to say that this experience is our experience. This slide on racism really has depth and meaning to me. The first time that I actually presented this slide was 2 days after George Floyd's murder, and I wept real time on a webinar with Cherished Futures for Black Moms and Babies. And I wept because when I looked at this and I saw that in 1964, in the after the Civil Rights Act was passed, that in this period of time, I can recall so many stories that were now my stories around racism, remembering stories of being with my mom when she was called out of her name, and then 10 years later as a university student having that experience. And I think what also is important for us, that from a generational standpoint, that for baby boomers, we are 2 grandparents away from an enslaved member in our family. So we're not talking about long time ago, we're talking about a continuum that is important in our lives. And it's this front and center to how racism has shown up in the social unrest that we're working with. The next slide here is very important to me. Again, as I talk about the generational audience, that it's important to look at that all of us bring lived experience to this work, and it has informed our vision statement, inspiring generational champions for resilience and good health. But here's something to really take into consideration, that for baby boomers, in terms of our age, or how we show up in this work, that we're legacy leaders, we're memory holders, and we're wisdom keepers. For Gen Xers, they're the game changers. They're the ones who are using critical race theory in this work. So it really becomes important to ground and to center who we are, and that we have a voice around the way that we are approaching the work from an academic standpoint, but also in terms of our leadership. When I look at our millennial leaders, they're millennial managers, they are rising stars. They're the ones who are really given the opportunity to bring depth to this work, and they have the ability to work with us who are at the top of our game. And then last, we have Gen Z, which are the social change leaders in early careers. And in actuality, they are either undergrads or they're just beginning their career. But what we all have in common is that in this lived experience, is from Emmett Till to George Floyd, that we have seen the public lynching of our people, that we have seen a backlash of fear that has happened within our community. So when we think about having two pandemics, the racism really is outweighing the actual COVID-19 in terms of the minds of our community, because we are seeing this on social media. We're reading about it all the time. COVID-19, you can't see anything without a COVID-19 pop up with it. But the backdrop to it is that, am I safe? And where do I build my safety net? One of the questions that students had asked, and I believe it was the first time this year, was in UCLA Honors Collegium, is to explain, Ms. Valentine, what is institutional racism, systemic racism, structural racism, and is it a difference? And when I read Dr. Ibram Kendi's book, How to Be an Anti-Racist, I learned from him is that racism itself is institutional, it is structural, and it is systemic. What we're addressing are racist policies. And what I'd like to say for all of us that are involved in developing policies is that policies are made by people, and we're part of a movement that we are disruptors, and we are offering clarification and dismantling racist policies so that we do have hospitals that are safe, that we do have practitioners who are building safety nets for us when we come in excuse me, into our care. So it's a new era that's happening. And in here, this is a go-to book that really explains that when we're talking about racist policies, then that's something that we're able to dismantle. And then very quickly here, I'm involved in several hospital quality improvement initiatives, but there is a burden that we're discovering. And I'm using Cherish Futures as my example. When I talked and opened up about community grief, I'm the one who really sat at a panel and looked at institutional racism, Black women, and community grief, and discovered that this burden that sits on our head, that sits on moms, she may have a good pregnancy outcome, but her experience may have just changed the way that she feels about her healthcare. And also, looking at institutional racism and stress, I just discovered with my hospital team at California Hospital, where I serve as the community advisor, is that when we start looking at why is it that there are 5 to 10% more hypertension rates, and it hit me real time, is that we are hypertensive because, and there's a high rate of preeclampsia, is because racism is sitting over our heads. So it's important for us to look at, how do we look at these measurements? These measurements help us to understand how we are able to close the gap. And we can be very specific about that for pregnant and parenting women. And then last but not least, this quote from Dr. Karen Scott, who is the principal investigator for the Sacred Birth Study, which is going on right now, is she said that we lack this ability to see Black births and Black women as valuable. So when we center these conversations about racism and about burden, it really is important for us to move forward into the healing conversation. So when we talk about healing, and I look at it again from a workplace standpoint, is that, excuse me, that we hear over and over from Black professionals how they are supervised by toxic management teams and navigate in toxic work cultures. And then when I hear from my ally, is that unintended harm by white progressives in the nonprofit sector, and it costs and its cost to all of us. Well, my colleague Cynthia Freeman and I, we presented and we went live with our case study about repairing harm and what it meant for us to understand that cultural humility is really about how we work together. So whether that is with Black-led or Black-serving organizations or with our hospital quality improvement teams, we're working with individuals, and cultural humility starts right there. And then again, if you are not familiar with this, this concept, it's called pet to threat. And what it means is that for many women of color, but specifically Black women, we come in, you know, our credentials say that we belong in this organization. And as soon as we're able to exercise our voice and we're able to really bring ideas to the table, then we're looked upon as being a threat. And the response is that, well, you're not really a fit in this organization. And then what happens is that those targets and attacks really help us to think, well, maybe I have failed. Something is wrong with me. So when I think about the burden, racism and the burden and the microaggressions and the mental health of Black college grads, this is our trajectory. What we were able to do in the AIM community is that I had an opportunity, along with Dr. Melissa Franklin, to co-facilitate a meeting after George Floyd's murder, which was called Waiting to Exhale, that was specific to Black staff and leaders to understand, I need a place to just exhale. I need to be able to breathe. Is my organization safe? Can we be a safety net to each other? Another action that we did was that just 3 days later, we had a convening for our own Black leaders, which we called Hurt and Hope, Healing and Action. But what I want to make a connection to is that it's the Generation X and it's the millennials who are now being faced with not only the pandemic, but the institutional racism for the first time, that they're understanding that there is a connection and how do I really deal with that? Those two factors are playing and wreaking havoc on our mental health as solution bearers in this work. And we also see this as being a challenge to the way that we're providing care. So in closing, I want to be able to offer to you a quote from WebMD that I was interviewed for in January of this year. And it says, you're either going to be a part of the problem or you're going to be a part of the solution. So all of us have to learn to speak a language of respect, speak a language of support, speak a language of healing, and speak a language of hope. We all have to take responsibility for that. And so I have here in my last slide quick links that you're able to take a look at some of the recent articles that speak about having a safe and sacred birth, and looking at some of the videos that help you to understand the work that we're doing in its genesis stage. And this was in 2019, and see how we're working together today. Thank you so much for having me and for listening. And again, it's for having me as your thought partner, as your collaborator, and bringing the lived experience and social service insights to this work. Thank you.
So I really wanted to thank all of our participants for an outstanding presentation. We are close to the top of the hour, so I wanted to give people a quick opportunity to be able to put questions in the question and answer box. I wanted to answer one question that was in the question and answer box that talked about emergency resources. Since this is a virtual continuing medical education, and in the COVID era, our virtual platform has expanded beyond Southern California. We even have folks call in from out of state. I can only answer the question about emergency resources within the context of larger counties in California. But the larger counties of California, such as Los Angeles County, San Bernardino County, Alameda, Sacramento, San Joaquin, they do have access to 24-hour mental health. And so if you go to your county's Department of Mental Health webpage, you can get a number for those. I cannot address what happens in, Del Norte County and La Frontera of California or other states, but at least in California, for most of our large urban counties, there is 24-hour mental health support from the local county health departments. And those are resources that all individuals have access to. One of the questions I was unable to answer that I would like to give to our panelists would be about domestic violence during pregnancy. Does it increase? If so, what might be the causes and what might be the tactics that physicians can or others involved with the mother can implement to help mitigate?
If it's okay, I'll kind of take a gander at that. I saw that some of those questions came up when I was speaking. So domestic violence or intimate partner violence, IPV, is unfortunately extremely common. There are studies that show that it does increase in pregnancy. It also increases in the postpartum. We don't, to the best of my knowledge, really don't know why that is. I know that in the OB clinic where I work, that asking about domestic violence is part of the basic screener that every patient gets from nursing staff and then from some of the community health workers that we work with. Interestingly, that question has not really made its way into mental health care at DMH, but again, we're working on it. And the only thing I would emphasize, there are two things I would emphasize. One is that, first of all, if you ask the question, be ready for the answer, right? So if you ask the question to someone who's pregnant or just had a baby, know what to do if they say yes. And that can vary anywhere from giving resources for hotlines or shelters to helping a woman create a safety plan with a packed bag and cash and copies of her ID, et cetera. So we generally have like very practical things that we do to answer that. The other is that it's also quite true that the first time you ask, she very well may not answer, that it may take a while to kind of develop enough trust so that she is willing to answer that question. Domestic violence has really been on the forefront this year because of COVID. A lot of women in the shelters basically got full. There have been some efforts by the city and state to open up hotel rooms for victims of domestic violence, but it is actually a leading cause of homelessness in women. Actually, 80% of women who are homeless because of domestic violence, which is a statistic I learned not long ago that just blew my mind. So again, asking about it is so important, but making sure that you have the resources to help someone respond appropriately is also important.
Dr. Dossett, might I add, and this is actually something I'm going to have to research and send to you, Dr. Carlisle, because I've been in some spaces with HRSA, and they actually have come up with a questionnaire that doesn't directly ask about the violence, but asks around it, and they're finding that more women will disclose. My brain has frozen on me. I can't remember the name of the form, but I have colleagues. But I think that's really, really important because they find that women are more likely to then disclose that there's something wrong. And just to remind us that the number 2 cause of death in Black women is homicide. Between 25 and 44. So
And this whole issue of having a resource and a plan after you ask the question, which is why, although AB 2193 is helpful because it mandates screening, that I wanted to have a bigger, broader conversation about, well, then what do you do? And my concern with the fact that domestic violence is becoming a pro forma question embedded in electronic health record systems really does not get people to talk. And yes, I I think if you have a resource, we'll make sure we spread it through the webpage and our meetings so that folks can take it to their practice settings and add something that is more useful, because the patient actually is comfortable telling you what's going on. And then we've traditionally supported Genesee House, and I think if we all understand how common it is, whether you're calling to us from Columbus, Ohio, and we've got some friends out there who call in for our meetings, or here in Los Angeles, that you can start thinking about the community resources to help once you've asked the question and the next steps. So I think with that information, we do keep up with folks, and we know that people will be getting emails with their e-blasts so they can get their CEUs, and we can also use that process as a way to provide this information for individuals who participated in this CME. And so the Los Angeles Department of Public Health has resources, and so does the Department of Mental Health, Los Angeles, California Department of Mental Health. There are also some resources from individuals, and we will try to get any other information out in the process of the electronic blasts. We've run over time, and I'm trying to be respectful of people's time, in the fact that I know it is Saturday and everybody's got things to do. I have a few things I want to remind people of, since it's that time of the year. For those so let's see, any last quick questions I can hit? So I think because we're over time, I'm going to just remind ABWP members that ballots for our election went out on Monday for the new board. We need our ballots back by the 28th. Check your spam folder, and if you didn't get it, please reach out to the correspondence email. We as an organization have been very blessed this year. As an organization, we had our record-setting charity benefit and raised $55,000 for scholarships in our virtual program. And we encourage everyone else who is a supporter to pass on the blessings. You can pass on the blessings if you choose to support Amazon instead of local community businesses by having us, ABWP, identified as your charity of choice on the smile.amazon webpage. We do get money, and we've gotten money there. Traditionally, we have a toy drive and we have a Christmas party. Obviously, we're not doing that this year. In the past, we have supported special needs, the Special Needs Network, which supports families of patients with autism in South Central Los Angeles. And we have also supported the Faith Foster Family Network, which helps kids who are aging out of the foster network system. The board voted that we will match the first $1,000 of donations by our membership to these two organizations. And since it's bad enough to be in this situation, but to be in this situation in a pandemic, we really would encourage all participants on this call to please support the board's designated nonprofit partners for this holiday season. We can't have a normal Christmas, but we'd like to pass on the blessing. The other blessings we would like to encourage is that LA Unified, like many other school districts, is having Zoom challenges educating kids of color. And so there is an opportunity to virtual mentor with LACES, which is a program for at-risk kids in LA Unified. I believe other school districts have it, but I live in LA Unified, so this is the one we're talking about. So if you want to be offering 1 hour of virtual mentoring a week with LA Unified, you have my email. The office will be closed, and we plan to have our first meeting of 2021 on January 9th. So I thank you all for sharing your time with us. This is our last meeting of the year. I really want to thank our speakers for an excellent program supporting something that's very, very near and dear to my heart. The office will be closed on the 20th, but I'll be counting ballots until the 28th. But we really hope to see all of you in the virtual universe for our first meeting of the year, January 9th at 2 p.m. Thank you very, very much for your time. I thank the speakers, and please look for your CME documents so that you can get your credits, and have a blessed holiday season. Thank you very much, one and all.